Hi, welcome to Chapter 4 and welcome to Unit 2. Unit 1 was about who you are becoming as a doula and how to stay safe and sustainable in this work. Unit 2 is where the clinical material starts. 6 chapters that walk you through pregnancy and prenatal support from the first positive test all the way to the day that labor begins. We start with this, the most important sentence I've got to say for this whole unit. The 2 most important decisions a pregnant person makes about her care are who and where. Who is going to be her trusted provider and where is she going to deliver? Because those 2 choices shape everything that follows. So before we talk about physiology, before we talk about nutrition, or even about complications, you need to understand the system that she is moving through. And that is what this chapter does. So let's get started with the philosophy underneath everything. There are 2 primary models of maternity care in the United States. Most clients experience a blend of both, but the underlying philosophy shapes how long their appointments are, what questions get asked, when interventions are recommended, and how the provider talks to them. The simplest way to hold the difference is this. In the medical model, you are sick until proven healthy. In the midwifery model, you are healthy until proven sick. This is not a criticism of either approach. It is a description of 2 genuinely different starting premises. The medical model approaches pregnancy as a significant event that carries risks, requires vigilant monitoring, and ready access to interventions. Its core assumption is that any pregnancy could become complicated and that proactive management saves lives. And when things go wrong medically, this model does save lives, and that is not a small thing. The midwifery model approaches pregnancy as a healthy, normal process unless the evidence indicates otherwise. The body knows how to grow a baby and give birth, and this role, the provider is there to monitor, to support, and intervene only when the clinical picture warrants it. Both are valid, and both have legitimate places. Most clients will experience some blend of the 2. Your job is not to steer her towards one or the other. Your job is to understand both well enough to support her effectively within whichever one she's navigating. Now, the providers who practice within those models, there are 4 main types who you will see in this work. Obstetrician gynecologists, or OBGYNs, are the medical doctors with a 4-year residency in obstetrics and gynecology. They're trained surgeons capable of performing cesarean sections, managing obstetrics emergencies, and the like. They practice the medical model, and they are the right choice for high-risk pregnancies. They are also a perfectly safe choice for a low-risk pregnancy, and many clients choose them. Certified nurse midwives, or CNMs, are advanced practice nurses with graduate training in midwifery. They practice primarily within the midwifery model, with longer appointments and more emphasis on shared decision-making. The research shows that for low-risk pregnancies, the CNM-led care model produces excellent outcomes with lower cesarean rates and higher client satisfaction. Certified professional midwives, or CPMs, are trained for out-of-hospital birth. They attend home births and work in freestanding birth centers. Their legal status varies a lot by state. Here in Louisiana, CPM practice is not currently licensed, which is a complicated reality your clients deserve to understand. And family practice physicians who manage low-risk pregnancies are particularly in rural areas where OB access is limited. The scope of practice reminder from Unit 1 absolutely applies here. You do not recommend specific providers, not by name, not by practice, not even by implication. What you can do is help your client identify her own priorities and ask the questions that she should ask. Her decision, her values, her relationship, your support. Now, onto the rhythm of prenatal care. Here is the cadence for a low-risk pregnancy. Every 4 weeks from the first appointment through about 28 weeks, then every 2 weeks from 28 weeks to 36 weeks, then weekly from 36 weeks until birth. High-risk clients are going to have quite a few more appointments. At every routine visit, regardless of trimester and regardless of provider, your client gets the same standard checks. Blood pressure, because things like preeclampsia can't be felt. A urine dip, because protein alongside high blood pressure equals preeclampsia. Glucose could also suggest gestational diabetes, and bacteria means that she's got a urinary tract infection, which could trigger preterm labor if untreated. So there are 3 clinical concerns from one 30-second urine test. Weight is also tracked across the pregnancy for different patterns going up and down. And after 20 weeks, we start to assess fundal height with a tape measurer. And what we're looking for is the number to the fundus of the uterus, which is right at the top, from the pubic bone, to be about as many centimeters as the client roughly is weeks of pregnancy. We're also going to assess for fetal heart tones, usually with a handheld Doppler. For many clients, that one is the emotional highlight of every appointment. This chapter is going to walk you through those major prenatal tests, from dating ultrasounds at 6 to 10 weeks, all the way through the biophysical profile in the 3rd trimester. Read it. Know what each test is looking for. You do not interpret results, and you do not advise on which test to take, but you absolutely should know which one each is, so that when your client calls you panicked from the parking lot because the doctor mentioned that her placenta is low-lying, you know what that means, and you know whether it's an emergency or you can help her slow down and find her questions. There is one distinction in this chapter that I want you to know cold, because clients get it wrong constantly, and the confusion causes real unnecessary distress. Screening tests and diagnostic tests are not the same thing. A screening test tells you that the probability something is present. A diagnostic test tells you whether it's actually there. The clearest example of this is the NIPT, or the non-invasive prenatal test. It's a blood draw usually offered around 10 weeks that screens for chromosomal conditions, including Down syndrome, trisomy 18, and trisomy 13. It's a screening test. A high-risk NIPT result does not mean that the baby has a chromosomal condition. It means the probability is elevated, but it's a diagnostic test, an amniocentesis, chorionic villus sampling. That's what's going to actually confirm the diagnosis. So why does this matter to you as a doula? Because a client who receives a high-risk NIPT result may be on your phone within the hour, terrified, believing that she's just been told that her baby has some horrible illness or disease. She has not been told that. She has been told that the risk is higher than average. She needs to understand the difference. Help her slow down and find the right questions to bring back to her provider. Here's a piece of this chapter that I really want you to internalize, because I don't think we usually cover this well enough. Your support of a client's prenatal appointments happen in 3 parts: before, during, and after. Before the appointment, you could do a brief check-in. Do you have anything in mind? Any questions from our last conversation? Let's make a list. Most clients can think of about 3 or 4 things that they mean to ask, and they always forget almost half of them the second they sit down in the exam room. A list texted to her before the appointment is one of the most practically useful things that you can do. During the appointment, you may or may not be there. Most prenatal visits, you're not. But when you are, your role is specific. You listen. You take notes so she doesn't have to hold everything in her head. You help remember the questions she prepared. You do not ask your own questions. You do not speak for her. After the provider leaves the room, you can check in. What did you hear? What questions do you have now? After the appointment, you debrief. And this is where most of your valuable work is going to happen. And it is most consistently the skipped step. The research on it is actually unambiguous. Patients retain less than half of what they're told in the clinical encounter, and retention drops even further when the information is emotionally charged. Most clients walk out of significant appointments not fully having absorbed what was said. So a day or 2 after a call or a text, not a how did it go, which invites a summary, but tell me what you walked out of there carrying, and then listen. Reflect back what you heard. Surface the questions that did not occur to her until she was in the parking lot or talking to her partner that evening. Help her understand what was actually told. After that debrief, repeated week after week from 6 weeks to 40 weeks, is how a client comes into labor knowing her care, trusting her care team, and feeling supported the whole way through. So read chapter 4 carefully, sit with the 2 models, get comfortable with the 4 different provider types. Memorize those standard checks at every appointment so you can talk through them with your client, and start practicing the before, during, after rhythm with the next prenatal visit that you support. And before you move on, ask yourself one question. What kind of provider would feel right for you if you were sitting in the prenatal chair? Not because you're recommending, just because you want to know what your own answer is to those questions so you can help your clients ask even better ones for theirs. I'll see you in chapter 5.